why do we, almost never get varicose veins in our arms? I mean, think about it.
Right. It's one of those questions that seems so incredibly obvious once you hear it, but, well, it completely upends how you think about your own body.
It really does. Welcome to the Deep Dive. Today, we're jumping into this really fascinating set of clinical notes from Dr. K. Senthilkumaran from the Surgical Thinking Academy.
Yeah, it's his notes titled Diseases of the Veins, specifically Part 1.
Exactly. And that opening question about our arms,
Yeah.
it's exactly how he hooks his readers. Because logically, you'd expect symmetry, right?
You really would. I mean, we have 2 arms, 2 legs, a heart right in the middle, pumping blood to all of them.
Yeah, the plumbing is all connected. You'd think a disease that totally destroys the blood vessels in your calf would be just as likely to pop up and destroy the veins in your forearm.
But that symmetry is, it's kind of an illusion, especially when you factor in the physical world we actually live in.
Right.
Answering that question about why your arms are spared, that's basically the skeleton key to understanding exactly why your legs are just, well, condemned to suffer.
Because it shifts the entire conversation away from pure biology and directly into physics.
Exactly. Physics is the real culprit here.
And so that is our mission for today. We're taking these clinical notes, which map out this really high-level surgical anatomy and pathophysiology of the veins, and we're translating them.
Right. We're turning it into the story of a relentless 24/7 war that your body is fighting against gravity.
We're going to explore how your lower half is engineered to survive this fight, and the completely catastrophic microscopic chain reaction that happens when it loses.
Yeah, and we'll get into the sheer mechanical genius of how surgeons can locate an invisible, broken valve using literally nothing but a rubber band and the laws of fluid dynamics.
That's so cool. So to understand this war, we really have to understand the primary antagonist first, which is obviously gravity.
Right. So if we go way back, when human beings evolved to walk upright on 2 legs, bipedalism, it gave us massive evolutionary advantages.
Oh, sure. We could see over tall grass. We freed up our hands to build tools, all that good stuff.
Yeah, exactly. But our internal plumbing, it had to rapidly adapt to a really radical new reality.
Right, because if you're a quadruped like a dog or a horse, your heart and your vital organs and, well, the majority of your blood vessels are all operating on a relatively horizontal plane.
Exactly. The heart pumps blood out, and it circulates back without having to fight this massive vertical climb.
But the very second we stood up, we created a towering vertical column of fluid inside our own bodies.
And in fluid dynamics, that's known as a hydrostatic column.
Okay, let's break that down for a second.
Sure. So if you imagine a really tall vertical tube just completely filled with water, the water at the very bottom is bearing the physical weight of all the water stacked up above it.
So the taller the tube, the heavier the weight.
Right, and the higher the pressure down at the bottom.
Which brings us right back to that initial question, right? The arms versus the legs.
Exactly. The distance from your fingertips up to your heart is a relatively short hydrostatic column.
So even if your arm is just hanging straight down at your side, there just isn't that much fluid stacked up above the veins in your hand.
Right, there's not enough to create overwhelming back pressure. And furthermore, think about how you actually use your arms throughout a normal day.
I mean, they're in near constant motion.
Yeah, you're picking up a coffee cup, you're typing, you're gesturing while you talk, like I am right now. You're reaching for a shelf.
So your hands are frequently raised up to, or even above, the level of your heart.
And every single time you do that, you invert the hydrostatic column.
Oh, wow. So gravity stops being an obstacle and instantly becomes an asset.
Exactly. It literally drains the blood out of your arm and just effortlessly dumps it back into your chest.
But the legs live a completely different, much more punishing existence.
Oh, absolutely. When you stand up, you are creating an unbroken column of blood from the right atrium of your heart all the way down to your toes.
And we spend just hours upon hours with our legs trapped in that downward dependent position.
Yeah, sitting motionless at a desk for 8 hours, standing still behind a cash register, or, waiting in a massive line at the airport.
We're basically demanding that those lower veins pump a heavy, sluggish fluid straight up a vertical pipe, fighting gravity every single second of the day.
And the physical toll of that is just staggering. Dr. Senthilkumaran actually calculates the pressure inside the veins at your ankle.
Yeah, I saw that in the notes. It can reach roughly 80 to 100 millimeters of mercury just from standing still.
Right. And I really want to pause on that number, because 80 to 100 millimeters of mercury is a profound amount of pressure.
It really is. I mean, when you get your blood pressure measured at the doctor, A perfectly healthy systolic pressure, the maximum force of your heart violently contracting and blasting blood into your arteries, that's around 120.
Exactly. So we're talking about a pressure resting on the delicate, thin-walled veins of your ankle that is almost as high as the pressure exiting your heart.
Except this isn't an active muscular pump. This is literally just dead weight.
It's the equivalent of the plumbing system in a massive skyscraper.
Yes.
Yeah.
I love that analogy. If the heart is the penthouse suite on the 50th floor, then the ankle veins are the basement pipes.
And those basement pipes have to be structurally capable of holding back the crushing weight of the water in all 49 floors above them.
Which really forces the question, if the baseline physical pressure on our legs is that intense, why aren't we all just walking around with permanently swollen, ballooned-out legs from the moment we become toddlers?
Because evolution didn't leave those basement pipes defenseless. A healthy, normal venous system is this marvel of engineering explicitly designed to beat gravity.
Right, and the notes lay out what we can sort of think of as the three defenders of the lower limb.
Yeah, these are the anatomical structures that keep that towering hydrostatic pressure from just tearing the veins apart.
Let's break down those three defenders. I want to start with the first and arguably the most famous one, the venous valves.
Ah, the venous valves. They're basically structural bulkheads.
So inside the lumen, or, the hollow center of the leg veins, the body has grown these really delicate bicuspid valves.
They look a bit like tiny, translucent swallows' nests attached to the inner wall, and they're essentially one-way doors.
Okay, so when the blood is pushed upward toward the heart, the force of the flow easily pushes these little doors open, right?
Right, it just allows the fluid to pass right through. But the instant that upward push stops, gravity immediately tries to pull that heavy column of blood back down toward the feet.
And as the blood falls backward, it physically catches inside the cups of those little swallows' nests.
Exactly. The sheer weight of the blood violently snaps the two doors shut against each other,
forming this perfect watertight seal.
And the true mechanical genius of this design is that these valves are spaced out at regular intervals all the way up the leg.
Oh, I see. So they effectively take that one massive, crushing hydrostatic column from the heart down to the ankle and just chop it up.
Yes, into dozens of tiny, completely separate, low-pressure columns.
So the vein at your ankle isn't actually bearing the weight of the blood up in your thigh?
Not at all. It's only bearing the weight of the blood up to the very next valve, which is maybe just a few inches above it.
It's like climbing a super long ladder that has a series of trap doors installed along the way.
That's a great way to picture it. You climb up past the first trap door, and it shuts beneath you.
So if you slip, you don't fall all the way back down to the ground. You just fall an inch onto the closed trap door.
Exactly. The valves hold the line. Which brings us to the second defender, the vein wall tone.
Right, because those valves can only meet in the middle and form a seal if the walls of the pipe around them hold their shape.
Exactly. A healthy vein wall is a really complex matrix. It isn't just a lifeless plastic tube.
Right. The notes say it contains collagen for sheer tensile strength, elastin to allow it to bend and stretch, and a layer of smooth muscle.
So when that 100 millimeters of mercury pressure pushes outward, trying to expand the vein, the smooth muscle, and the collagen push back?
They maintain the precise diameter of the vein.
Right, because if the wall were to give way and stretch out like, say, an overinflated balloon...
the walls would pull away from each other.
Exactly, and those two little valve doors in the middle wouldn't be able to touch anymore.
They'd just be left flapping in the breeze. Utterly useless.
Completely useless. So the wall integrity is just as vital as the valve itself.
Which leaves the third defender, and this is where the system goes from passive defense to active offense. Right?
Yes, the calf muscle pump. The text affectionately refers to this as the peripheral heart, or the second heart.
I just love this concept because arteries have the actual heart actively driving their flow.
Right, the heart squeezes and that high-pressure wave ripples all the way down to your toes.
But by the time the blood makes it through those microscopic capillary beds in your feet and enters the venous system to begin the journey home,
all that momentum is totally gone.
Yeah, the pressure is essentially zero. The blood has to get back up to the chest, but it has zero engine pushing it from behind.
So it requires external assistance. And in the lower limb, that assistance is provided by the massive, bulky muscles of your calf.
Specifically the gastrocnemius and the soleus muscles.
Yeah, got it. The primary deep veins of your leg don't just run right under the skin. They're actually buried deep inside these muscular compartments.
And the notes point out that these compartments are wrapped in this really tough, unyielding layer of tissue called the deep fascia.
Right. The deep fascia acts like a rigid outer casing.
So when you take a step, you flex your calf muscle, the muscle belly physically bulges and thickens.
But because it's trapped inside that rigid fascial casing, it has literally nowhere to expand outward.
Oh, so it has to expand inward.
Exactly. It expands inward, violently compressing everything inside that compartment.
Including the deep veins. It literally wrings the deep veins out like a wet sponge.
Yes. It aggressively squeezes the pipe. And because the one-way valves below the muscle are forced shut by this sudden pressure spike, the blood cannot go down.
So it has only one available exit.
Right. It shoots straight upward, propelled toward the heart with incredible force.
Every single time you take a step, your leg is effectively acting as a secondary heart.
It's amazing, isn't it? You contract the calf, the blood shoots up, the valve shuts to catch it, the muscle relaxes, the vein refills from below, and you take another step.
It's this perfect self-sustaining loop.
And this loop leads to a deeply counterintuitive reality about the venous system.
Which is?
Well, because of this pumping action, taking a brisk walk actually drastically lowers the resting venous pressure in your leg.
Wait, really? Walking lowers the pressure?
Yeah. Standing perfectly still is what maxes out the pressure and stresses the system. Engaging the second heart drops the pressure and clears that stagnant fluid right out of the limb.
Wow. Okay, but to really visualize how this blood is moving, we need to look at the map of the highways themselves.
Right. Dr. Senthila maps out the anatomy of the leg veins in the notes.
He divides them into 3 distinct interconnected systems. And this isn't just trivia, right?
No, not at all. Understanding this map is literally the only way to understand how the whole system breaks down later.
Okay, so let's get into it. The first of these 3 systems is the superficial system.
Right. And as the name implies, these are the veins sitting in the subcutaneous fat, just beneath the skin.
But importantly, they are above that tough layer of deep fascia we just talked about.
Exactly. These are the blue or green lines you can actually see on your legs.
And the most important thing to know about the superficial system is that it's essentially just the local road network of the leg.
Yeah, it's responsible for draining the skin and the superficial tissues, but it is definitely not the main highway.
I think the notes said it only carries about 10% of the overall blood volume back to the heart.
That's correct. Just 10%. And there are 2 main players on these local roads. The first is the Great Saphenous Vein, or the GSV.
Oh, the GSV. The notes make it sound like an absolute titan of human anatomy.
Oh, it is. It's the longest single vein in the entire human body.
That's incredible. It begins all the way down on the inside of the foot, arising from the dorsal venous arch.
Right. And the notes mention a very specific anatomical landmark here. The GSV runs consistently just in front of the medial malleolus.
That's the bony bump on the inside of your ankle, right?
Exactly. And it's such a reliable anatomical constant that surgeons historically knew they could always find it right there in an emergency.
Like if they needed to establish a rapid IV line or something.
Exactly. So from the ankle, it travels straight up the inside of the calf, crosses the inside of the knee, and runs all the way up the inner thigh until it reaches the groin.
And what happens at the groin?
At the groin, it dives deep. It passes through a hole in the fascia called the saphenous opening and empties all its contents into the massive femoral vein.
And that specific junction point is called the saphenofemoral junction, or the SFJ.
Right, and it is guarded by a highly, highly critical one-way valve.
Now, the GSV is fascinating to me because it occupies this really unique space in modern medicine.
It does, because while its day job is just acting as a local road for 10% of your leg's blood,
Cardiothoracic and vascular surgeons view the GSV as the body's ultimate built-in spare pipe.
yes, it is the absolute gold standard conduit for bypass surgery.
Let's expand on that. If a patient has severe coronary artery disease, meaning the arteries feeding their heart muscle are clogged with plaque, and they're on the verge of a massive heart attack.
A surgeon can open up their leg, harvest a long segment of this great saphenous vein, and physically sew it into the chest to bypass the blockage.
That is just wild to me.
It works so well because it's so long, it's relatively thick-walled for a vein, and it's easily accessible right under the skin. It's the perfect biological replacement part.
It can literally save your heart. Or, the notes mention it can be used to bypass a blocked artery in the leg to save the limb from amputation.
Exactly. Which brings up a massive non-negotiable clinical imperative.
Right. You never, ever surgically destroy or remove a healthy great saphenous vein.
Never. You do not throw away the spare tire just because you don't happen to need it today.
Makes total sense.
Okay.
So alongside the GSV, The superficial system also features the small saphenous vein, or the SSV.
Right. This one starts on the outside of the foot, runs behind the lateral ankle bone, and travels right up the middle of the back of the calf.
But instead of going all the way up to the groin, like the GSV does,
The SSV dives deep right behind the knee to join the popliteal vein. This is the sapheno-popliteal junction.
but the notes point out that unlike the very predictable groin junction, this knee junction is, like, anatomically treacherous.
A nightmare. The exact height at which the SSV joins the deep system varies wildly from patient to patient.
Really? Like, how much variance?
A lot. Sometimes it joins high up in the lower thigh, sometimes lower down in the calf. It makes operating on the back of the knee a much more complex surgical puzzle.
Got it. So we have the local roads handling 10% of the traffic.
Right. Which brings us to the second system, the deep system.
This is the massive, high-speed underground freeway.
Exactly. These veins are buried deep beneath the fascia, nestled inside the muscles near the bones, and they carry 90% of the venous return.
90%. And these deep veins have a really brilliant anatomical feature, don't they?
They do. They're called venae comitantes, which translates to companion veins.
Companion veins,
That-
meaning they travel right alongside the major high-pressure arteries of the leg.
Right, they almost wrap around them. And it's a remarkable piece of evolutionary synergy.
Because the artery is thick-walled and pulsing violently with every beat of the heart.
And because the thin-walled deep vein is pressed tightly against it, every time the artery expands, it physically nudges the vein.
That continuous rhythmic bumping gently massages the vein, adding just a tiny bit of extra forward propulsion to that sluggish venous blood.
It's brilliant.
It's like drafting behind a massive 18-wheeler on the highway. You're letting the powerhouse next to you break the wind and pull you along in its wake.
That's a perfect analogy. So we have this superficial local roads on the outside and the deep, high-speed freeway on the inside.
But they're separated by a tough wall of fascia. So how does the blood actually get from the skin to the main highway?
That is the job of the third venous system, the perforators.
The perforating veins. And according to the notes, these are arguably the most critical points of failure in the entire limb.
Oh, without a doubt. They are short, horizontal connector veins that literally perforate or pierce right through the deep fascia.
I just picture them as the one-way on-ramps. You're driving on the superficial road, you take a perforator on-ramp, you plow through the fascia, and you merge onto the deep highway.
And just like a real highway on-ramp, tracheal is strictly regulated. It only flows in one direction.
So the perforators contain their own one-way valves.
Exactly. They're designed to allow blood to flow inward from the superficial system to the deep system. They absolutely forbid blood from flowing outward.
And anatomists have mapped these on-ramps extensively, right? Naming them after the surgeons who originally described them.
Yeah, you have the Hunterian perforators high up in the mid-thigh, the Dodd perforators down in the lower thigh, the Boyd perforator just below the knee joint.
And perhaps most importantly, the Cockett perforators in the lower calf and ankle area.
The Cockett perforators are clinically infamous.
Why is that?
Well, they sit directly in the zone where the hydrostatic pressure is at its absolute peak.
Down by the ankle.
Right. So when the system begins to fail, these lower on-ramps are often the very first structures to blow out, initiating this cascade of destruction in the tissue around the ankle.
Okay, let's put this entire machine into motion, just to summarize. You take a brisk walk, your calf muscle contracts.
The peripheral heart squeezes the deep veins inside the fascia.
The blood is under immense pressure, and it wants to escape in literally every direction.
It tries to go down, but the deep valves snap shut.
It tries to blast sideways out through the on-ramps into the superficial veins.
But the perforator valves snap shut, locking the door.
So the only path left is the path of least resistance, straight up the deep highway to the actual heart.
Right. Then the muscle relaxes, the deep veins fall to near zero pressure, and they immediately siphon new blood inward from the superficial system through those perforator on-ramps, draining the skin.
It is a flawless mechanical cycle.
It is, until it isn't.
Right, because the reality of Dr. Cynthia Kumaran's clinical notes is that no machine runs flawlessly forever.
Yeah.
We have to explore what happens when the parts start to wear out.
Exactly. The onset of varicose veins, this visible, bulging, torturous superficial vessels, that's a sign that the high-pressure deep system is leaking into the low-pressure superficial system.
And understanding how that leak starts requires dividing the disease into two distinct categories, right? Primary and secondary failure.
Right. Let's start with secondary failure. If a patient comes into a clinic and their veins have rapidly deteriorated in a matter of months, or if the severe bulging is completely localized to just one leg while the other looks perfect.
The surgeon's mind immediately goes to secondary failure.
Yes, secondary failure means the plumbing didn't just passively wear out from old age. Some violent external event actively destroyed it.
So what's the most common culprit for that?
A previous deep vein thrombosis, or DVT.
Which is a blood clot that forms inside the deep venous highway.
Exactly. When that clot forms, it acts like wet cement. It hardens and adheres to the delicate leaflets of the deep venous valves.
Oh, yikes. So even if the body eventually dissolves the clot, or the patient takes blood thinners, the damage is already done.
Yeah. The valve is scarred, stiffened, and permanently incompetent. It can never close again.
And without those bulkheads, the deep system just loses its ability to protect the lower leg.
The full weight of the hydrostatic column crashes down, the pressure spikes, and the blood forces its way backwards through the perforator on-ramps.
Blowing their doors right off the hinges and flooding the superficial veins.
Exactly. Now, another major secondary cause is pregnancy.
Okay, how does pregnancy cause that kind of damage?
Well, it's a double hit to the venous system. First, you have the profound hormonal shifts, specifically a massive increase in progesterone.
And what does the progesterone do?
It chemically relaxes the smooth muscle in the vein walls throughout the entire body, making them way more prone to stretching.
Ah, okay. So the walls are weaker, and the second hit.
The physical mass of the expanding uterus, it sits directly on top of the inferior vena cava and the iliac veins in the pelvis.
Oh, so it's physically impeding the flow of blood trying to return from the legs?
Precisely, which is actually the exact same mechanism as the next secondary cause, a pelvic or abdominal mass.
Like a tumor.
Yeah. If a patient has an undiagnosed ovarian tumor or a large fibroid in their pelvis, it acts as a physical roadblock on the main highway back to the heart.
Wow. Imagine a massive traffic pileup shutting down all northbound lanes of a freeway. The cars behind the crash don't just disappear, right? They try to find an alternate route.
That's exactly what happens. The blood pressure builds up behind the tumor, forces its way backward down the leg, blows out the perforator valves, and shunts the entire volume of deep venous traffic out onto the superficial local roads.
But the superficial veins are absolutely not engineered to carry 100% of the leg's blood volume.
Not even close. So they dilate massively under the strain, becoming huge secondary varicose veins.
Okay, the final secondary cause mentioned in the notes is just wild to me. An arteriovenous fistula.
Yes. This is an abnormal, direct short-circuit connection between a high-pressure artery and a low-pressure vein, skipping the capillary bed entirely.
So it instantly blasts the fragile vein with arterial level pressure.
Right, blowing it up like a balloon.
Okay, so those are the clear, identifiable villains of secondary failure. But the notes point out that the vast majority of patients sitting in a vascular clinic do not have a tumor, they haven't had a DVT, and they don't have a fistula.
Right, most of them have primary varicose veins.
And this is the slow, gradual, seemingly inevitable breakdown of the system over years and decades.
Exactly. And even within the medical community, there is a massive ongoing debate about exactly how primary failure begins.
It's a true chicken and egg scenario. The notes outline two highly debated theories.
Right. The first is the descending theory, also known as the valvular theory. This is the top-down approach.
Okay, top down. Walk me through that.
The descending theory posits that the breakdown begins with a single catastrophic failure at the very top of the system.
Like at the saphenofemoral junction.
Exactly. For reasons we don't fully understand, maybe chronic straining, heavy lifting, or simply genetic bad luck, the primary valve guarding the SFJ in the groin just gives way.
Oh, wow. So when that main gate breaks, the entire weight of the blood in the abdomen is suddenly allowed to free fall backward into the great saphenous vein.
Right. And the very next valve down the line suddenly takes a massive, unprecedented hit of pressure.
It fights to hold the line, but eventually it fatigues and snaps.
Yes. Now the pressure falls to the third valve, then the fourth.
The incompetence just cascades down the leg like a slow-motion line of falling dominoes.
Destroying the superficial system from the groin all the way down to the ankle.
I mean, that makes a lot of intuitive mechanical sense. It's a pure plumbing failure.
It does. But then you look at the second theory, the ascending or vein wall weakness theory.
This one takes a completely different angle. It argues for a bottom-up approach.
Right. The ascending theory suggests that we have been blaming the valves for a crime they didn't commit.
Oh, I like that phrasing. So who is the real culprit?
This theory argues that the primary defect is actually genetic. The patient is born with an inherent microscopic weakness in the collagen and elastin matrix that makes up the wall of the vein.
Meaning the pipe itself is fundamentally flimsy.
Yes. And if the pipe is inherently weak, it is going to fail at the point of maximum stress first.
And we know that the hydrostatic pressure is highest at the very bottom of the leg, near the ankle.
Exactly. So the vein wall down near the calf starts to dilate and stretch outward.
Okay, let's use an analogy to clarify this, because the notes had a really good one. Imagine a set of double doors, the valve leaflets, installed inside a wooden door frame, the vein wall.
Right. The descending theory says the doors won't stay shut because the metallic hinges snapped. The doors themselves are broken.
Right. But the ascending theory says, no, the metal hinges are perfectly fine. The doors are trying to close.
But the entire wooden door frame has warped and widened so much that the two doors simply can't reach each other in the middle anymore.
The structural failure of the wall has literally pulled the valve leaflets apart.
Exactly. The medical term for that is secondary incompetence. The valve is failing, but only because the wall failed first.
And the ascending theory carries a lot of weight because it elegantly explains why varicose veins have such a massive hereditary component.
Right. You don't necessarily inherit bad valves. You inherit a weak collagen profile from your parents.
And once that lowest section of veins stretches out, the local valve fails, the pressure pushes up to the next segment, stretches that wall, and the destruction marches upward toward the groin.
It's exactly bottom up.
So we have a debate, top-down versus bottom-up. Broken hinges versus warped frames. Does it actually matter which one is definitively right?
Well, from the perspective of pure scientific inquiry, yes, it's a fascinating puzzle. But clinically, as Dr. Sento Kumaran synthesizes for his students, the end result is functionally identical.
Right. Whether the destruction cascaded down from the groin or crept up from the ankle, the patient arrives at the exact same terrifying destination. Sustained, ambulatory venous hypertension.
Ambulatory meaning walking. Even when the patient is actively walking around trying to engage the calf muscle pump, the pressure just refuses to drop.
Because the valves are gone, the perforators are blown wide open, and the peripheral heart is just uselessly sloshing blood back and forth in a broken system.
The pressure in the lower leg remains at a constant, crushing 100 millimeters of mercury.
And this is where the story pivots from a mechanical engineering problem into a full-blown biochemical nightmare.
Yeah, the high pressure isn't just stretching the major veins anymore. It's being transmitted outward all the way down into the dermal microcirculation.
The dermal microcirculation, you mean the incredibly fragile microscopic capillary beds that keep the skin alive.
Exactly. And this transition in the notes is chilling because you realize that blood pressure doesn't just exist in a vacuum. It pushes against the boundaries of the body.
When that pressure hits the tiny capillaries in the skin around the ankle, a region doctors call the gator area, it triggers a sequence of events that literally dissolves the patient's skin.
It's awful. Medical science has spent decades trying to figure out the exact cellular mechanics of this destruction.
But why does high venous pressure lead to an open ulcer? Right.
Exactly. And the notes map out the evolution of our understanding, starting with the fibrin cuff theory proposed by researchers Browse and Burnand in 1982.
Okay, so in 1982, they looked at these high-pressure capillaries and theorized that the sheer mechanical force was stretching the pores of the capillary walls wide open.
Right. And fibrinogen, which is this massive protein normally restricted to the inside of the bloodstream, where it waits to help form clots.
It gets squeezed out through these stretched pores into the surrounding tissue.
Exactly. Once outside the vessel, that fibrinogen polymerizes into tough, insoluble strands of fibrin.
And Browse and Burnand looked under a microscope and saw that this fibrin was wrapping itself around the outside of the capillaries, forming a dense, constricting cuff.
It's the equivalent of taking a porous soaker hose in your garden and wrapping it tightly in thick layers of waterproof duct tape.
The researchers posited that this fibrin cuff acted as an impenetrable physical barrier. Oxygen and vital nutrients flowing through the blood could no longer diffuse out through the capillary wall into the skin tissue.
The theory was elegant and widely accepted. The skin was literally suffocating.
Starved of oxygen, the tissue suffered chronic hypoxia, died, and sloughed off, leaving a gaping venous ulcer.
It makes total logical sense. But science is a process of constant revision. The notes reveal that this theory was later completely dismantled.
Right. Other researchers came along, ran more sophisticated tests, and realized that while the fibrin cuffs absolutely exist, they aren't the airtight seal Browse and Burnand thought they were.
Yeah, oxygen molecules are tiny. They can easily slip through the gaps in the fibrin mesh. The tissue wasn't suffocating.
Oxygen levels in the skin were actually relatively normal.
Exactly. So if the tissue isn't starving for oxygen, what is killing it?
Which brings us to 1988 and Coleridge-Smith's white cell trapping theory.
The notes highlight this as the most widely accepted theory in modern vascular medicine. And frankly, the mechanism is horrific.
It really is. It starts with the same foundational problem: high venous pressure.
Right. Because the pressure on the venous side of the capillary bed is so abnormally high, it creates massive resistance against the incoming blood from the arterial side.
So the pressure gradient flattens out.
Meaning the blood isn't flowing smoothly from the artery through the capillary and into the vein anymore. The flow slows down to an agonizing crawl.
It basically creates a microscopic traffic jam.
And sitting in that traffic jam are the leukocytes, the white blood cells.
Normally, these are the heroic shock troops of the immune system. They zip through the bloodstream at high speeds, constantly patrolling for bacteria, viruses, or traumatic injuries.
But because the blood flow in these ankle capillaries has ground to a halt, the white cells experience something called margination.
Margination, what does that mean?
They drift out of the main current, bump against the wall of the capillary, and get physically stuck.
Ah, and a trapped white blood cell is a highly unstable, dangerous entity.
Very. When they get stuck, they become activated. Their programming tells them that if they have stopped moving, they must have arrived at the site of a severe injury or a major infection.
So they believe they are in a war zone.
And so they deploy their weapons.
These trapped, confused leukocytes begin violently degranulating.
They release massive amounts of potent proteolytic enzymes, chemicals, literally designed to dissolve proteins along with highly reactive oxygen-free radicals, and a massive storm of inflammatory mediators directly into the healthy capillary wall and the surrounding skin.
If we go back to the traffic jam analogy, it is as if a massive convoy of heavily armed emergency responders gets stuck in gridlock on a bridge.
Right.
They can't move, they get panicked, they assume the bridge is under attack, and they just start blindly firing their weapons and detonating explosives, ripping the concrete to shreds.
That is a brutally accurate visual. The white cells destroy the endothelial lining of the capillary.
This destruction drastically increases the permeability of the vessel, causing massive amounts of fluid to leak out into the leg.
Furthermore, the dead cells physically plug the capillary, causing localized microinfarctions, tiny pockets of tissue death.
The skin is literally being digested and destroyed from the inside out by its own immune system.
It's wild. And as if that wasn't bad enough, the notes introduce a third layer to the nightmare: the trap hypothesis, formulated by Falanga and Eaglestein in 1993.
This theory answers a very specific question. Once the white cells blow a hole in the skin and an ulcer forms, why does the body completely fail to heal it?
Right. The trap hypothesis looks back at those stretched, leaky capillaries. It isn't just fibrinogen leaking out. The high pressure forces other massive macromolecules into the tissue, specifically one called alpha-2 macroglobulin.
And these leaked macromolecules act like chemical sponges scattered throughout the wound bed.
Right. When the brain realizes there is an ulcer on the ankle, it sends in repair crews. It dispatches vital growth factors and matrix-building proteins to lay down new skin.
But before those growth factors can do their job, they bump into these leaked macromolecules and become chemically bound to them.
They get trapped. The macromolecules literally hold the growth factors hostage, rendering them completely unavailable for tissue repair.
So the wound is constantly being chemically bombarded and expanded by the trapped white cells, and simultaneously starved of the specific biological materials it needs to rebuild.
It's a state of perpetual, agonizing destruction.
Dr. Senthil beautifully summarizes this entire catastrophic sequence in 4 steps.
Right, let's walk through them. Step 1. The pressure causes a capillary leak. Fluid, proteins, and entire red blood cells are pushed out of the vessel and into the surrounding tissue of the ankle.
Step 2 is what happens to those escaped red blood cells. They're trapped in the tissue outside of the bloodstream.
So they quickly die and break down.
And when a red blood cell degrades, it releases the iron contained within its hemoglobin,
which deposits in the skin as a compound called hemosiderin. And this produces a very distinct, dark, rusty brown pigmentation.
Step 3 is the massive inflammatory response triggered by the white cells.
Right. This manifests as severe venous eczema, dry, incredibly itchy, inflamed skin, and a terrifying hardening of the fat layer called lipodermatosclerosis.
We will definitely talk about what that looks like in a moment.
And finally, step 4 is the ultimate failure: tissue breakdown.
The skin gives way entirely, forming a chronic, weeping venous ulcer that just refuses to heal.
Exactly.
So we spent a lot of time down at the microscopic level looking at cells and pressure gradients. But this isn't just an academic exercise.
No, this process is happening inside real people.
What does this invisible cellular war actually look and feel like for the patient who finally walks into the surgeon's clinic?
The clinical presentation is basically a masterclass in reading the body's warning signs.
The most common symptom, the thing the patient initially complains about, is often cosmetic at first, right?
Yeah, they see the dilated, tortuous, rope-like veins twisting down their calf, but it rapidly moves way beyond aesthetics.
Patients describe this deep, aching pain, a profound sense of heaviness, as if they're dragging weights around their ankles.
They call it having tired legs, and the defining characteristic of this pain is its temporal rhythm.
The timing is a massive diagnostic clue.
Huge. A patient with venous disease often wakes up in the morning feeling relatively normal.
Why? Because they've spent the last 8 hours lying flat in a bed. The hydrostatic column was eliminated.
Exactly. Gravity wasn't punishing the legs, and the swelling had time to slowly drain back into the central circulation.
But the moment they stand up and start their day, the clock starts ticking.
The pressure builds, the fluid leaks, the veins stretch. By mid-afternoon, their shoes feel tight.
By the evening, their ankles are swollen, the skin feels like it's bursting, the ache is intolerable, and the skin over the bulging veins might be fiercely itchy due to the inflammation.
Many patients also report severe, agonizing muscle cramps in the calf during the night as the muscles spasm in response to the massive fluid shifts.
The notes highlight a critical distinction here that every clinician has to memorize. The behavior of the pain separates venous disease from arterial disease.
Let's logic through this. We established that the pain from venous disease is a dull, heavy ache that is severely worsened by standing completely still.
Because the hydrostatic pressure maxes out.
But strangely, the pain is actively relieved when the patient starts walking or when they lie on the couch and elevate their legs on a pillow.
Now, contrast that with arterial disease,
Right.
specifically a condition called intermittent claudication.
In arterial disease, pipes bringing fresh oxygenated blood down to the leg are clogged with cholesterol plaque.
So if you have arterial claudication, standing perfectly still doesn't hurt at all. Your leg muscles aren't doing any work, so their demand for oxygen is very low.
The blocked artery can supply just enough oxygen to keep them happy at rest.
But the moment you start walking, the calf muscles begin working furiously. They scream for more oxygen.
The clogged artery physically cannot deliver enough blood to meet the demand.
The muscle rapidly begins to suffocate, switching to anaerobic metabolism, which generates lactic acid.
And this causes a sharp, brutal cramping pain that forces the patient to stop walking entirely.
It's a perfect mirror image. Arterial pain is triggered by walking and relieved by standing still.
And venous pain is triggered by standing still and relieved by walking because walking engages the second heart, drops the pressure, and pumps the stagnant fluid out of the leg.
Your body is explicitly telling you whether it has an oxygen delivery problem or a fluid drainage problem.
It's brilliant clinical deduction.
Okay, moving from symptoms to signs, the things the doctor can physically observe, we enter the realm of chronic venous insufficiency, or CVI.
The surgeon immediately looks for the bulging veins. Then they check for pitting edema.
Pitting edema is a fascinating physical sign. The high venous pressure forces water out of the capillaries, waterlogging the tissue around the ankle.
If a doctor firmly presses their thumb into the swollen skin just above the ankle bone and holds it there for a few seconds, it physically displaces the fluid in the tissue.
And when they remove their thumb, a deep, visible dent or pit remains in the skin for quite a while before the fluid slowly seeps back in to fill it.
Exactly. Below the swelling, the doctor looks for the C4 skin changes.
The hemosiderin staining that rusty, dark brown discoloration caused by the thousands of microscopic internal hemorrhages.
They look for the red, scaly, violently itchy patches of venous eczema.
And then they look for the hallmark of advanced, late-stage destruction, lipodermatosclerosis.
I want to spend a moment on this because the visual description in the text is so incredibly vivid.
It describes a leg as looking like an inverted champagne bottle.
It is a striking and tragic physical transformation. Think about the shape of a normal, healthy lower leg.
The calf muscle up top is thick and bulky, and the limb tapers smoothly and gently down to a slender ankle.
But in a patient with severe chronic venous hypertension, the relentless bombardment of inflammatory enzymes and free radicals from those trapped white blood cells completely ravages the lower third of the leg.
The subcutaneous fat layer literally dies fat necrosis.
And In an attempt to heal, the body replaces that soft fat with dense, woody, unyielding scar tissue. This is fibrosis.
The skin becomes indurated. It feels like touching a piece of hard plastic or wood. It binds tightly to the underlying fascia and bone.
Because scar tissue naturally contracts and shrinks as it forms, this woody fibrosis acts like a tight corset, physically squeezing and strangling the lower third of the leg, making it abnormally narrow.
But above this corset of scar tissue, the upper calf is still relatively soft, and it remains massively swollen with backed-up fluid and dilated, bulging veins.
So you have a wide, swollen upper calf that abruptly pinches inward to a hard, narrow, woody ankle.
It looks exactly like a champagne bottle that has been flipped upside down.
Scattered within that woody tissue, the surgeon might also spot atrophy blanche.
These are small, ivory-white, star-shaped scars on the skin.
They represent localized graveyards, areas where the intense pressure and inflammation have completely obliterated the capillary beds, leaving dead, bloodless scar tissue in their wake.
And ultimately, all of this leads to the venous ulcer itself.
It usually forms in the gaiter area, most commonly just above the medial malleolus, the inside ankle bone.
It's an open, weeping, incredibly painful wound that simply refuses to heal because the macromolecules have trapped all the growth factors.
The notes are also careful to point out that this isn't just a slow, chronic misery. There are acute, life-threatening complications to severe varicose veins.
The first is superficial thrombophlebitis.
The stagnant, sluggish blood inside one of those massive, bulging, superficial veins can suddenly clot.
The vein becomes a rock-hard, violently red, and exquisitely painful cord under the skin.
The second acute complication is severe hemorrhage.
As the veins bulge outward over the years, the skin stretched over them becomes paper-thin and friable.
And the wall of the vein itself is under 100 millimeters of mercury of pressure.
If an elderly patient with this condition simply brushes their ankle against the sharp corner of a coffee table or lightly scratches an itchy patch of eczema, that high-pressure varix can easily rupture.
And because there are no working valves to stop the flow and the pressure is so high, the bleeding isn't just a trickle.
It can be a brisk, massive, pulsatile hemorrhage.
It's a genuine medical emergency that requires immediate elevation of the leg and intense direct pressure to stop.
To manage all of this complex clinical data to track a patient's progression from a minor cosmetic complaint to a life-threatening hemorrhage, the medical community established a universal language.
Right. It is called the CEAP classification. CEAP.
Dr. Senthil Kumaran notes that doctors use this scale to categorize the slow-moving disaster of venous disease. The C stands for clinical signs, and it is a journey from 0 to 6.
C0 is the invisible phase. The patient's legs ache, the pressure is building, but the skin looks completely normal to the naked eye.
C1 is the first crack in the armor. The high pressure blows out the tiny superficial venules right at the surface, creating telangiectasia, the classic web-like spider veins.
C2 is the arrival of true varicose veins. The local roads have officially expanded into bulging, rope-like structures.
C3 is when the lymphatic system gets overwhelmed and the fluid starts pooling, causing visible pitting edema around the ankle.
C4 is the critical tipping point. This is the moment the surgeon knows the white cell trapping and the microscopic cascade have begun in earnest.
C4 is the arrival of the brown hemosiderin staining, the eczema, and the hardening of lipodermatosclerosis.
C5 means the patient has suffered a venous ulcer in the past, but the body somehow managed to cover it with a fragile layer of scar tissue.
And C6 is the end of the line, an active, open, weeping venous ulcer.
The notes mention that the E, A, and P stand for etiology, why did it happen, anatomy, where's the failure, and pathophysiology, is it reflux or blockage, but the C scale is the vital shorthand.
It allows a surgeon in London to instantly understand the exact severity of a patient referred by a doctor in Tokyo.
And once the surgeon knows how bad the disease is, they face the ultimate challenge. They have to find out exactly where the plumbing is broken.
Which brings us to the final and, in my opinion, the most purely fascinating section of Dr. Senthil Kumaran's notes, the clinical examination.
A patient is sitting on the exam table. They have the aching pain, the bulging veins, maybe a C4 champagne bottle leg.
Before the surgeon can even think about picking up a scalpel or a laser to fix the plumbing, they have to find the exact point of the invisible leak.
And this is where physical medicine becomes an art form of logic and deduction.
The absolute non-negotiable first rule of the venous exam, bolded in the notes. Always examine the patient standing up.
Which, based on everything we've discussed about hydrostatic pressure, is entirely logical.
If you ask the patient to lie down on the exam table, You immediately eliminate the hydrostatic column.
Gravity drains the leg, the veins collapse and disappear, and the disease essentially hides itself. You have to evaluate the plumbing system under maximum stress to see where the leaks are.
You start by just looking inspection. You trace the geography of the bulging veins.
If the varicosities are massive along the inside of the calf and sweeping up the medial thigh, you immediately suspect the great saphenous vein is failing.
If the bulging is isolated to the back of the calf, you suspect a small saphenous vein.
Then the surgeon uses their hands palpation. They feel the temperature of the skin, checking for the heat of inflammation or thrombophlebitis.
And the notes detail a series of incredibly clever bedside tests. Let's start with Morrissey's cough test.
Morrissey's test is a brilliant use of the body's own internal pressure dynamics to test a valve.
The surgeon places their fingers lightly over the groin, specifically over the saphenofemoral junction, where the superficial GSV dives deep to join the main highway.
Then they ask the patient to cough aggressively.
Let's logic through the mechanics of a cough. When you cough, you violently and instantly contract your abdominal muscles.
This creates a massive, sudden spike in intra-abdominal pressure. That pressure wave travels straight down into the venous system of the pelvis.
If the main valve at the SFJ is healthy and competent, that high pressure wave slams into the valve, the door snaps shut, and the force is completely stopped. The leg is protected.
But if that valve is broken, if the descending theory has kicked off the disease, that high pressure wave blasts straight backward through the incompetent valve.
And because the surgeon has their fingers resting right over the vein, they will actually feel a sudden expansile thrill.
It feels like a physical shock wave or a pulse of fluid hitting their fingertips. The cough test instantly confirms that the primary gate at the groin has fallen.
Following that logic, the surgeon needs to check the rest of the gates, the perforator on-ramps down the leg. The notes describe Fegan's test.
Remember that perforators pierce directly through the tough, fibrous, deep fascia.
When a perforator valve blows out and the vein dilates massively to accommodate the backwards flow of blood, it physically stretches and widens the hole in the fascia.
It creates a permanent structural defect. Fegan's test involves marking the bulging superficial veins with a pen while the patient is standing.
Then the surgeon has the patient lie down, elevating the leg so the veins empty completely.
With the fluid gone, the surgeon runs their thumbs firmly down the line of the emptied vein, pressing into the muscle.
They are feeling for literal gaps. The text describes them as knuckle-like defects in the deep fascia.
When the surgeon's thumb sinks into a small circular divot in the otherwise tough fascia, they have located the exact geographical coordinates of a blown-out perforator.
It's like finding a pothole hidden under a puddle. But the absolute crown jewel of the venous physical exam, the test that requires pure fluid dynamic logic, is the Trendelenburg test.
This is how a surgeon determines whether the system is leaking from the top down or from the inside out.
It is a beautiful diagnostic sequence. Step 1. The patient lies down. The surgeon elevates the leg high above the level of the heart.
Gravity goes to work, completely draining the limb. All the massive, bulging varicose veins empty out and lie flat against the skin.
Step 2. While the leg is still elevated and empty, the surgeon takes a tight rubber tourniquet and ties it firmly around the upper thigh, directly below the saphenofemoral junction.
This tourniquet acts as an artificial valve. It physically clamps the great saphenous vein shut, completely blocking any flow from the top down.
Step 3. The surgeon asks the patient to stand up quickly. Now, the observation begins. The surgeon watches the empty veins with the tourniquet still securely tied. This is test 1.
Okay, let's analyze the fluid dynamics here. The patient stands up. The top valve is blocked by the rubber tourniquet.
If, within 15 to 20 seconds of standing, the surgeon watches those flattened superficial veins rapidly fill up and bulge with blood from below the tourniquet, what is the logical conclusion?
The conclusion is absolute. The blood filling those veins cannot possibly be coming from the main junction at the groin because the tourniquet is blocking that path.
Therefore, the blood must be coming from the deep system, leaking outward through incompetent broken perforators lower down in the thigh or the calf. The leak is coming from the side.
It is deductive perfection. But what if the patient stands up, the tourniquet is on, and the veins stay relatively flat? Nothing fills up from below.
Then the surgeon moves to test 2. They suddenly release the tourniquet.
If, the exact second that rubber band is popped off, a heavy column of blood instantly crashes down from the groin and violently fills the varicose veins, you have your diagnosis.
The perforators below were fine. They held the line. But the moment you removed your artificial valve at the top, the system flooded.
This proves that the main SFJ valve is wildly incompetent. The leak is coming from the top.
And Dr. Senthil Kumaran notes that you can refine this logic even further with the multiple tourniquet test.
You empty the leg, but instead of one tourniquet, you tie 3 or 4 rubber bands at different levels: upper thigh, lower thigh, upper calf.
It isolates the leg into distinct segments. The patient stands, and you just watch to see which specific segment between the tourniquets fills up with blood first.
It pinpoints exactly which individual perforator on-ramp has failed. It is like stepping on a garden hose at different intervals to figure out exactly which inch of the rubber has a hole in it.
But the most high-stakes test in the entire clinical repertoire is the Perthes test. While Trendelenburg looks for leaks, the Perthes test checks for blockages.
And getting the Perthes test wrong can literally cost a patient their leg.
Let's walk through the mechanics of Perthes. It is designed to test the patency, meaning the openness of the deep venous highway.
The surgeon asks the patient to stand up, allowing the superficial varicose veins to fill. Then, the surgeon ties a tight tourniquet around the mid-thigh.
This clamps off the superficial system, trapping the blood in those bulging veins. Finally, the surgeon asks the patient to walk briskly around the room or repeatedly rise up and down on their toes.
By making them walk, the surgeon is forcing the patient to engage the calf muscle pump. The peripheral heart starts powerfully squeezing the deep veins.
Now, if the deep system is healthy, open, and functioning normally, a specific sequence occurs.
The calf muscle squeezes and the blood is propelled up the deep highway, bypassing the tourniquet entirely.
Because the deep system is draining the leg so efficiently, blood from the superficial veins is sucked inward through the perforator on-ramps to join the deep highway.
As the patient walks, the surgeon will actually see the bulging superficial veins shrink and flatten out. That is a negative Perthes test, and it is wonderful news. It means the deep highway is wide open.
But what if the deep highway is blocked? Let's say the patient had an old, massive DVT blood clot that completely cemented the deep vein shut.
This is where the physics turn violent. The deep system is a dead end. But the tourniquet is still on, and the patient is still walking.
The calf muscle violently squeezes the deep veins, but the blood hits a brick wall. It cannot go up. The pressure spikes exponentially.
The blood desperately searches for an exit. It forces its way backward, blasting outward through the perforators and floods into the superficial veins.
But remember, the surgeon has tied a tourniquet around the superficial vein higher up.
So the blood is trapped. The superficial veins won't empty. In fact, they will visibly engorge, becoming massively prominent, tight, and distended.
And the patient will immediately experience severe, bursting, agonizing pain in their calf. This is a positive Perthes test. It proves the deep system is obstructed.
And the notes state a massive, bolded medical imperative right here. Never strip superficial veins if the deep system is blocked.
If a surgeon skipped the Perthes test, looked at those ugly, bulging superficial veins, and decided to just surgically remove the great saphenous vein to make the leg look better, they would be committing a catastrophic error.
They would be destroying a vital bypass. If the deep system is blocked by a clot, that bulging varicose superficial vein is the only pathway left for blood to escape the leg.
It is carrying 100% of the traffic. If a surgeon strips it out, the blood has literally no way to get back to the heart.
The leg will swell massively, the tissue will die from venous gangrene, and the patient will likely face an amputation.
It brings profound weight to Dr. Senthil Kumaran's warning. Surgery must be understood, not memorized.
You cannot just memorize the steps to strip a vein. You have to deeply comprehend the invisible fluid dynamics of the limb before you make a single cut.
The final bedside test the notes mention is elegantly simple. The Schwartz tap test. It checks the entire length of the vein for valves.
The surgeon places one hand at the very top of the GSV in the groin. With their other hand, they sharply tap or flick the bulging vein much lower down on the calf.
If there are healthy, competent valves anywhere between those two hands, they will instantly absorb and block the physical shockwave of the tap.
But if the valves are completely obliterated, the vein is essentially just an open, unbroken column of fluid.
When the surgeon taps the calf, that impulse travels straight up the column of water, and they will physically feel the shockwave hit their top hand in the groin.
It is a crude but effective way to confirm that the entire pipe is hollowed out and useless.
We have covered an immense amount of physical and biological territory today.
We really have.
We started with a simple question about why our arms don't get varicose veins, and it pulled us into a deep dive on the evolutionary consequences of walking upright.
We established that our lower limbs are locked in a high-pressure battle against gravity, relying on the brilliant engineering of one-way valves, elastic walls, and the pumping action of the calf muscles to survive.
But whether through the sudden trauma of a blood clot, the pressure of a pregnancy, or the slow genetic warping of the vein walls, the system can break.
And when it does, the hydrostatic column crashes down, permanently raising the pressure in the ankle.
And that mechanical failure triggers a microscopic catastrophe. The pressure slows the blood to a crawl, creating a traffic jam where panicked white blood cells marginate, get trapped, and release toxic enzymes that digest the skin.
The leaking macromolecules trap the growth factors, preventing any hope of healing, and dragging the patient down the CEAP ladder toward a chronic, agonizing ulcer.
And to fight back, surgeons rely on pure deduction. They use gravity, tourniquets, and the patient's own muscle pump to map out the invisible leaks, ensuring they only operate on the broken local roads while protecting the vital deed highways. It is an incredible synthesis of physics and biology.
It truly is.
But I want to leave you with a final thought, building on that terrifying microscopic cascade. Right now, almost all surgical treatments for advanced venous disease revolve around the plumbing.
Right, if a vein is leaking, surgeons tie it off, they strip it out, or they burn it shut from the inside with a laser. They eliminate the broken pipe to lower the pressure.
But if we accept the reality of Coleridge-Smith's white cell trapping theory, the high pressure isn't actually what dissolves the skin. The pressure just causes the traffic jam.
The actual physical destruction of the tissue, the ulcer, the brown staining, the woody fibrosis of the champagne bottle egg is entirely executed by your own trapped, confused white blood cells.
Furthermore, the trap hypothesis proves the wound won't heal because essential growth factors are chemically bound up by macromolecules.
So here's the provocation. What if the future of treating this disease shifts away from the scalpel?
What if, instead of physically cutting out veins to manipulate pressure, medical science develops a targeted biochemical therapy, a localized treatment that simply turns off or desensitizes those trapped white blood cells?
It is a profound shift in thinking. If you could pharmacologically prevent the leukocytes from degranulating and releasing their destructive enzymes, and if you could introduce an agent that dissolves the macromolecule traps to free the growth factors, you could theoretically heal the skin and close the ulcer completely even while the mechanical plumbing remains broken and the pressure remains high.
Exactly. It is a brilliant example of how truly understanding the microscopic why, the cellular behavior has the power to completely revolutionize the clinical what. The day might come when a patient with severe lipodermatosclerosis doesn't need a vascular surgeon to strip their veins, but rather an immunological cream that tells their white blood cells to stand down.
That would be amazing.
We want to thank you so much for joining us on this deep dive into the hidden, high-pressure world of human plumbing. The next time you find yourself stuck in a long line at the grocery store, feeling that dull, heavy ache start to creep into your calves, do your anatomy a favor. Take a short walk. Do a few calf raises. Appreciate the incredible evolutionary engineering happening just beneath your skin and give your second heart a chance to beat.